ROSC or spontaneous circulation, here starts this post-cardiac arrest care. We mainly focus on optimizing ventilation and circulation. We need to preserve heart, brain, tissue functions and maintain the blood glucose levels. So we have two phases here, and continued management and additional emergency. So the ROSC is happening, we need to maintain the airway. Early placement of endotracheal tube can be advised, and we need to manage the respiratory parameters. Like we need to start the breathing respiratory rate of 10 breaths per minute, and maintain the saturation of in between 92 to 98%. And we need to titrate the PaCO2 levels in between 35 to 45 millimeters of mercury. Then we need to manage the hemodynamic parameters. Like we need to maintain the systolic blood pressure of more than 90 millimeters of mercury and mean arterial pressures of more than 65 millimeters of mercury. Then we need to obtain a transient ECG. Then here starts this continuous management and additional emergent activities. Here, after obtaining a 12-lead ECG, we need to consider for an emergency cardiac intervention if there is a acute STEMI presentation or unstable cardiogenic shock, or there is a mechanical circulatory support if needed. Then we need to check if the patient is following comments or not. If the patient is following comments, yes, and the patient is awake, we can continue for the other ICU critical care management. I'll discuss later. Other critical ICU management. If the patient is not responding to voice comments and still the patient is comatose, we can go for a TTM, targeted temperature management, brain CT, EEG, either intermittent or continuous, and either ICU management. We need to evaluate and treat rapidly reversible etiologies, and we need to involve the expert consultation for the continued management. So, other critical managements include we need to monitor the core temperature, either esophageal temperature or bladder or rectal temperatures. We need to maintain normoxia, euglycemia, normocapnia, and EEG monitoring is advised. And we also should follow lung protective ventilation, stress ulcer prophylaxis, and DVT care and enteral feeds. A few reversible causes like 4H and 4Ts, hypoxia, hypovolemia, acidosis, hypo or hyperkalemia, hypothermia. Then 4Ts like cardiac tamponade, tension pneumothorax, toxins, and thrombolysis, cardio or pulmonary causes. A few word on targeted temperature management. This targeted temperature management should be started as soon as possible, especially when the patient is comatose and not responding to comments. This begins at a temperature of 32 to 36 degrees Celsius, maintained for 24 hours by using cooling devices with a feedback loop. This is targeted to maintain a neuroprotective strategy. Each 1 degree Celsius temperature can reduce cerebral metabolic oxygen requirements by 6 degrees Celsius. So less excitatory amino acids and free radical production will be there. There will be, we can initiate this technique using surface cooling methods or intravascular cooling catheters or rapid infusion or cold saline ice packs. Other than that, we also can go for a setting targeted temperature. Like after ROSC, mostly the temperature will be around 35 degrees Celsius. We can go for two approaches, either a therapeutic hypothermia or targeted normothermias. Here, therapeutic hypothermia, the temperature will be in between 33 to 36 degrees Celsius. Here, targeted normothermia, we need to maintain temperature in between 36.5 and 37.5 degrees Celsius. Time for TPM, we should start as early as possible, preferably in a hospital setting, rather than going for a pre-hospital settings. Delayed targeted temperature management is also done when the patient has an acute STEMI on ECG, and the TPM can be started once revascularization has occurred. We need to maintain this TPM for at least 24 hours, and we need to monitor core temperatures. During this, we need to maintain adequate sedation, and vitals monitoring should be done. For every 4 hours, we need to do a CBC electrolytes, coagulation profile, cardiac enzymes, and lactate level. And this coming to rewarming, there will be it should be a slow and optimal rate of 0.25 to 0.5 degrees Celsius per hour can be done. Reborn hypothermia can cause a worse neurological outcomes. Prognosis, we can check for the clinical examination like pupil or cordial reflexes, neuroimaging, and EEGs. Outcome after 72 hours, we need to check them ideally. Other than that, side effects like shivering, coagulopathy, arrhythmias, fluid or electrolyte disturbances can be seen, and hyperglycemia also can be seen. So that's all.
What is the importance of this topic, post cardiac arrest care?
Sir, once ROS is obtained, there is an increased chance of mortality in next 24 hours. We need to stabilize this patient in that critical period so that the patient is not getting worsened.
Excellent, very good. So there is a chance that patient can arrest again. Okay. So having succeeded in your resuscitation by proper CPR or defibrillation, once a return of spontaneous circulation happens, we have to sustain that so that patient does not go back to have a cardiac arrest again. Okay? That is the reason why they have given a topic called post cardiac arrest care. So how to maintain that return of spontaneous circulation and further evaluation of the neurological, especially we do not know how much of damage could have been done by the cardiac arrest to the cerebral circulation and how much of hypoxia could have happened to the brain. So that is the main reason why we want to sustain that perfusion and oxygenation to the tissues and prevent a re-arrest occurring again. That is the reason for this topic being given. And you have, I think, covered all the points.